Hello, everyone. A warm good evening to you all. Thank you for joining in to yet another session, CME session with none other than Dr. Aduja Rahman Mukherjee. At Meribari, we believe that we need to be continually updating ourselves with our medical knowledge. And with that in mind, we have Dr. Aduja here taking multiple CME sessions. She's been taking it for many, many months now. For all the past CME sessions, if you would want to go through them, you can go to Meribari's YouTube channel, and there is a playlist there. You can listen to all her previous talks so that you can enrich yourself. Today, we have a wonderful topic that Dr. Aduja is going to take, which is a case-based discussion on the different kind of common blood reports that we see in our OPDs. I will hand it over to Dr. Aduja without any further delay. Over to you, Dr. Aduja, for a fantastic session ahead.
Thank you, Gauri. So today, as Gauri already mentioned, we are here to discuss some interpretation of the blood reports. But when we are saying that why we are doing so, what I have seen over last few years of my career, that nowadays it's an increased tendency for people to bring a huge load of blood reports, as they do sometimes, not because they have any problem, because they want to go for annual health check, or sometimes they do have problem, they do the test themselves and they bring it to us. And sometimes different doctors, including ourselves, we ask for some blood tests. But in those huge list of results, we miss certain important things. And we have a tendency to do a bulk of tests rather than rationalizing our thought and decide on doing which test to do. And if our mind is blocked up by saying that, oh, this is the thing, so this is the diagnosis, then we might miss on a lot of things. So to highlight on that, I chose this topic of this. Just a second, let me share the screen with you. What do my blood reports say? So this is the topic today. So let's go to this case history. As it is a case-based discussion, let's discuss based on the cases. So first case, as you can see on the screen, that a 32-year-old lady presents with tiredness, poor concentration, and loss of memory. She also complains of hair fall and pins and needles in her fingers. She is diabetic for the last 2 years and is on metformin and sitagliptin. So there are a few blood tests there. So just go through them. It is on your screen, but I'm just reading them out. Hemoglobin 7.5, WBC is 6, platelet 140. So 140 lakhs. So MCV is 108, MCH 35, MCHC 33, and HbA1c 5.6. So I know sometimes in the end of the day, so maybe you have had a hectic schedule, so interpret all these results would be a bit tiring. But still, I would request you to go through the reports once and just jot down in your mind what is going on in your mind. Okay, so while you were thinking about it and trying to write it, so it would be great that if you write 1 or 2 things in the chat box so that we can understand. Gauri always say that you can write it down in chat box now, and then we can answer them when we see that.
Yes, you could write your interpretations or your thoughts in the Q&A section, and we will take it up as and when. Here you could write what you think about the case or any questions that you may have as well.
Thank you, Gauri. So the case 2. The case 2 is the same lady, perhaps, but a different presentation, not a different presentation, the reports are different. So a 32-year-old lady presents with tiredness, poor concentration, and loss of memory. She also complains of hair fall and pins and needles in her fingers. She is diabetic for the last 2 years and on metformin and sitagliptin. But here the blood result shows hemoglobin 7.5, WBC 6, platelet 180, MCV 78, MCH 26, MCHT 33, HbA1c 5.6. That means her diabetic is well controlled, in short. And the first one, again, I'm going back to the first one. So what is the diagnosis you are thinking about in this case? What is going on in your mind that, okay, the patient is in front of you with this report. So what are you thinking? We have to wait for 1 or 2 minutes to get 1 or 2 results. So please write down 1 or 2 answers for case 1 and case 2, maybe 1 answer for case 1 and 1 answer for case 2. If you think about more, you can write more. Say if you are giving a diagnosis and you found out the cause for that, you can write that as well. Unless you think about these cases, it would be very difficult to progress for you, for me, because it's all depends on these interpretations, and it will be interesting. Yeah, I think we have hit
Yes.
one answer.
Yes, so we have Dr. Musliha who has responded saying this could be vitamin B12 or folic acid associated blood report, something, maybe the deficiency.
Very good.
Yeah.
Thank you. So anybody else want to contribute? Maybe the case 2. So has case 2 been answered? Are you thinking about the next one?
Dr. Amir, you have raised your hand. You could just click on the Q&A section and type your answer. So, Dr. Audrija, I would want to go ahead. For case 2, I think with the MCV being low, I'll first think of iron deficiency. There could be other things as well. Maybe we need to do further more tests, I feel.
Right. So in broadly, the first one, we are thinking about anemia. Definitely there is anemia because hemoglobin is so low, but its MCV is so high. So we are thinking about macrocytic anemia. And in second case, it is the anemia is again the same 7.5, but MCV is so low that we are thinking of microcytic anemia. So we have to find the cause for macrocytic hyperchromic anemia in case 1, and second one, the microcytic hypochromic anemia. Now, if you see the first case, the platelet count, it is lower than normal, that you can see. And in the second one, the platelet count is normal. Sometimes in this case, the platelet count may be on the higher side as well. So remember not to interpret only the hemoglobin with MCH. Also look at the WBC and platelet counts. So these are important. So these are the 2 things we are now. Definitely you have made your provisional diagnosis. Let's see, what other tests would you like to recommend in first visit? You mentioned about that you like to do some other tests. So can you tell me what are the other tests you would like to do to find out? So I'm just opening the first case. It would be easier for you. So for first case, what are the other tests you would like to recommend? Yes, Gauri, you can go ahead and see a couple of things. So while others are writing, so if you are writing in the QA box, it would be good.
Dr. Vishwesh has said that he would like to do peripheral smear, iron profile. I think this is for the second case. I think for the first case, we had Dr. Moshika who had talked about vitamin B12, folic acid to be checked.
Right.
Dr. also says blood picture to be looked at.
Good. So, but when we are diagnosing it as macrocytic anemia in first one and microcytic anemia in second one, we have to channelize our thought that which test we will go for macrocytic anemia and which test we will go for microcytic anemia. Now, macrocytic anemia, we usually in this first case where doctor said that yes, B12 and folate may be a main cause, the reason is not only it is macrocytic anemia, but the patient is on metformin. Long-term patient on metformin can develop B12 deficiency. From there, the macrocytic anemia can happen. But there may be other deeper cause for that. So TSH and liver function test also we will do because these are major causes of macrocytic anemia. Also, history of alcoholism is important here. So B12, folate, TSH, LFT, and in the history, if there is any history of alcoholism. Now, in nowadays, we are seeing a lot of cases where this two kind of anemia, macrocytic, microcytic, or rather iron deficiency and the B12 deficiency are coexisting. And because this patient's hemoglobin is pretty low, if you say 7.5, so there might be a doubt that whether only iron deficiency is giving this problem or rather B12 deficiency is giving this problem or there is more to it. So though it is macrocytic anemia, I would like to do some iron study as well, like serum iron, total iron binding capacity, and ferritin. Creatinine, why I am interested in doing that, particularly in this case, because kidney failure is a very common cause of anemia, of chronic disease, which can balance both. I mean, it is normocytic, normochromic. So the deficiency, which is more, will pull the blood results towards that. But the other conditions may coexist. But say patient's pocket is not permitting too many tests. So if you are doing few tests, then B12, TSH, and LFT is mandatory. And if you do a ferritin on top of that, it would be good. And blood film, because blood film can give us a lot of information. When we talk about macrocytic anemia, there are two types of macrocytic anemia we divide. One is megaloblastic, where you see that cells with megaloblasts that say nucleus are now joined, 2, 3, 4 lobes are there. So which is typical of this B12 and folate deficiency. But there are non-megaloblastic pictures we can get in this liver failure or hypothyroidism or alcoholism. So these are the non-megaloblastic pictures. So blood film is very important. Also, you can get a picture where it is, whether it is microcytic or macrocytic or some other cells are there, which is contributing to it. So case 2, when we are dealing with the case 2, so it is the case of iron deficiency anemia. Definitely, we will give more importance to the iron study. Now, serum iron, serum ferritin, total iron binding capacity or transferrin saturation. Here, I would like to mention, sometimes this patient, as soon as they see their iron is low, they start taking replacement with iron. Now, this serum ferritin, this is a very dangerous thing in the interpretation because this is an acute phase reactant like CRP. Sometimes ferritin might be falsely high and you might interpret as, okay, ferritin is high, so maybe not an iron deficiency anemia. So in that situation, the serum iron and iron binding capacity will come into play. So just by doing serum iron and hemoglobin and ferritin may not give you the total picture of iron deficiency anemia. So if you are strongly believing it might be a case of iron deficiency anemia, then better you think about doing the other test. But if you are sure, no, there is nothing to do with iron deficiency, okay, you may go on with the other test because every test are expensive. So when you are ordering the test, think about the patient's pocket also. Hemoglobin electrophoresis is one test we would like to perform in a patient with iron deficiency anemia, but here it's important to explore family history. Family history or even past history, you can ask that when during your childbirth, what was your hemoglobin? Now, sometimes they were not sure whether that hemoglobin electrophoresis was done in pregnancy or not. If you are working in a very high-class locality where only posh patients are coming, they might give you the history that they have had this electrophoresis during pregnancy. But in suburb areas or in rural people, or even in other urban population, all of them might not have the facility of going to a big posh hospital or big posh gynecologist, so they might not have it. So be careful. Definitely in where the hemoglobin is low and you are suspecting this iron deficiency anemia, also go for creatinine. Creatinine, renal failure can give both normochromic normocytic or hypochromic hypochromic hypocytic anemia, microcytic anemia. In both the cases, it is important. Why I am putting so much importance to creatinine this time, because anemia in chronic renal failure is getting more and more importance nowadays, as the cases of both this idiopathic chronic renal failure are increasing, perhaps because of overuse of PPIs, and definitely the cases of diabetic renal failure are also on high. So considering both the cases, this creatinine level is taking place in this investigation. While you are checking for other things, also don't forget to do the creatinine. Also, we have seen a lot of cases where we are confused why this anemia is happening. This LFT and TSH will come into play, that they will say, okay, I'm not good. And particularly LFT, TSH, we know we do, B12 we do. Folate sometimes we don't do, but it's good to check folate. But LFT is one thing. So I'm just highlighting here that when you are not 100% sure about the cause, this LFT and creatinine, these are the two things you better add in your investigation, at least for once, while you're investigating somebody with anemia. Okay, so next slide is showing the patient's blood report. So in the patient's first case, where we are dealing with macrocytic anemia, we are seeing that her ferritin level is 8, B12 is 145, folate 1.8, TSH 9.2, LFT normal. So except TSH, I've given all the reports, normal values there for you to understand which is normal, which is not. Now, what is your diagnosis in this case? So case 1, the patient who comes with pins and needles, memory loss, hair fall, with a macrocytic picture, and now coming with more information there. So what is there? Because unless we say 1, 2, 3, 4 in the diagnosis, we just give them some medicine and send them home, that won't make them better. So what you are seeing in the report? Anything coming up, Gauri?
So I think here there are multiple issues that we see when we have this report. And as you mentioned, right, that we may just look at one aspect of it, but it's important that we get all these tests done, because here we have a B12 deficiency, we have low folate, but it's a hypothyroid state, ferritin is low. So we will have to kind of address all of these in the treatment line. Like all of these will have to be taken care of when we try the medications for this patient.
So yeah, so when we are saying it is what is your diagnosis? This is iron deficiency anemia, there's B12 deficiency, folate deficiency, and hypothyroidism. So one drug itself won't make the patient better. So we have to start them on multiple drugs. Now, with the hemoglobin 7.5 and ferritin 8, as it is pretty low, sometimes it is better to split the iron in 2 doses, one in the morning, one in the evening. Couple of things I would like to highlight here when you are treating a patient with iron therapy. One is never give the iron with antacid. Now, I specifically explain to my patients, when we are taking iron, it is in a ferrous state. it changes to peripheric state in the stomach, which needs an acid environment. So if you are taking antacid and blocking the acid, this iron won't get changed into the ferric state, and so it won't get absorbed. So there is no point having iron with this antacids. Now, many of the patients with this kind of, who are on metformin with diabetes, or who are on this chronic dyspepsia due to autonomic neuropathy for diabetes, or sometimes anemia itself can give rise to a bit of gastric irritation or gastritis. So these patients are self-medicating themselves with antacids. Now, sometimes just this PPIs, sometimes they take liquid antacids. So we have to tell them specifically. So if you ask me, I give them iron after lunch, and I ask them to take some lemon with the food because it's a citric acid. So maybe that will help the conversion of iron to ferrous state, from ferrous state to ferric state for better absorption. And if there is a folic acid deficiency, folate deficiency, I combine one iron with folic acid in the evening if the hemoglobin is this low, and I give iron with some vitamin C or just this lemon in the afternoon after lunch, and ask them to avoid antacid if possible completely, or if they take it, at least they should have 2-3 hours gap between antacid and the oral iron. So this is very important. Second is, as we are seeing that B12 deficiency is there, we will come to the management of B12 deficiency in detail. Folic acid, as I have mentioned, you can combine folic acid with iron, so that will help them. Now, TSH 9.2, yeah, there is some advice on starting TSH, hypothyroid drugs when the TSH goes above 10, but I would say 9.2 is a good level where you should start this thyroid drug, altroxin, thyronome, whatever is your choice. So accordingly, you can proceed with this. Iron replacement, B12 replacement, folate replacement, and treat hypothyroidism. Also, definitely, we have to give some dietary advice. When we talk about dietary advice, again, there is a false belief in the patients that foods which are red, like pomegranate, like beetroot, they are very rich in iron. Interestingly, they are rich in vitamin C. But if you go for iron replacement, there are some foods. In Bengal, we get a leaf, we call it kule khada. There is in different parts. Now this kuleron and other juices are tonics are coming up, but really that works well. So I don't know, you should know the local name of these kind of plants which are health. You just ask the patient to boil the leaf and have the water, but also that's raw banana, then spinach, then dates, rajma, these are very rich in iron. So you yourself need to know which foods are rich in iron. Because sometimes this is something people are misguided, that the red things are full of iron, so have red fruits or red vegetables that will help, but honestly, they don't. Now, symptoms of B12 deficiency, as we have seen in the first patient, that this is becoming a very common, like after D3, last 7-8 years, we were working on D3, and now we are more on B12. So this is like an epidemic. This is also happening, tiredness, hair fall. If there is a weight loss, think about that malabsorption, particularly celiac disease, and check folate level here. Peripheral neuropathy, and the neuropsychiatric effect, depression, psychosis, memory disorder. Mainly 2 or 3 things, that tiredness, hair fall, and peripheral neuropathy. These are the 3 things which are more important, but yes, with severe deficiency, it can happen. Now let's talk about an interesting case. A 45-year-old man presents with sore mouth, abnormal sensation in lower limb, visual problem, and memory loss with reduced attention span. Numbness started in toes and feet and now ascending upward. There is loss of balance with tendency to fall. On examination, there is pallor and he has beefy tongue. neurological examination, predominant loss of vibration sense with associated loss of pain and touch and temperature sense. Romberg sign is positive. Loss of ankle jerk with brisk knee jerk and eye examination shows optic neuritis. Now, Romberg sign, I don't know, sometimes we read this in medical school, and then as we start getting more experience in clinical studies and clinical practice, we forget about all those signs. It is just they ask the patient unsupported, crossing their hand in front of your torso, or they can just keep their hand straight by their side. You have to ask them to just keep the feet side by side and close their eyes, but make sure that you are holding the patient, or rather you give that assurance that if you fall, you can hold them. Because if they really are ataxic, they can fall. So that is why it is very important that you have to hold them. Now, anything is coming to your mind?
Dr. Amir has diagnosed it correct as SCID.
Subacute combined degeneration of the spinal. You are absolutely right, Dr. Amir. And sometimes when I am presenting a case on B12 deficiency and coming to this, it is easy to diagnose. But when the patient comes to a clinic with this kind of presentation, so the DD of Guillain-Barré or transverse myelitis, they do come. So that is why you have to examine the patient as a whole. And it is typical of this patient is this loss of the vibration sense. But all the other senses, they also go, but that later. And this ataxia and this loss of ankle jerk. And also definitely the beefy tongue will help you with this pallor. But the eye signs are not a feature of this Guillain-Barré syndrome. And transverse myelitis is also not a sign of, eye signs are not a part of transverse myelitis. So unless you examine the patient from top to bottom, sometimes patient get confused with these three diagnoses, whether it's a subacute combined degeneration or Guillain-Barré syndrome or transverse myelitis. But very good, Dr. Amir, for diagnosing us rightly. Now, high-risk groups of vitamin B12 deficiency. Nowadays, a lot of people are becoming vegans. Here also, I have to tell you something very interesting, which I've noticed. You can do an audit on that, or you can share your views on that. That, say, in South India, there are a lot of people who are vegetarian by birth. That means their families are vegetarian from ages. But now it is a vogue to become vegetarian in North India or eastern part of India, and sometimes people are going for this vegan option. The people who are vegetarian since birth, they have less problem with B12 deficiency than the vegetarians who become vegetarian in later part of their life. That is a very interesting observation I've made, but I would like to have your views. You can write even later on to me that whether you have experienced anything, if you work in different part of the country ever, or if you are working in South only or in North only, you will understand. We used to know that there is no vegetarian source of B12, but sometimes in some articles I've seen that milk, curd, these are good source of B12 also. Not good, but rather than better than nothing. And a lot of people who are vegetarian, they sustain on this paneer, curd, this milk. So maybe they get some source of vitamin B12 from there. But the problem is with vegans. Neither they are eating animal protein, nor they are having this kind of dairy products. So for them, B12 deficiency is massive. Malnutrition. So yes, with other nutritional deficiencies, or if there is a problem with absorption, including that celiac disease patients, they can have that. Drugs, remember PPI, metformin, and contraceptives. Interestingly, contraceptive also can cause B12 deficiency. Pregnancy, as two candidates are absorbing vitamin B12, and particularly in breastfed infants, if the mother is deficient, then they can develop. So, but in our day-to-day practice, two things I would like to highlight. One is vegans, another is drug, or vegetarians, another is drug. So think about them. Now, treatment of B12 deficiency, the question is whether parenteral or oral. Now, in fact, if you read the books, you will see that a lot of patients they will advise on parenteral therapy. Most of the books are written by the Western people. Now, their pernicious anemia is very common, but in our country, the dietary deficiency is very common. So in that situation, you can choose oral replacement first. If they are not improving on oral replacement, then you can go for injectable therapy. The reason I'm saying so, because it is not a just temporary replacement, because most of these patients, if they are vegans or vegetarians, they will remain vegans or vegetarians. So they won't change him suddenly to non-veg person. Very rarely I've seen they're changing just because of they develop B12 deficiency. They will start eating a lot of non-veg stuffs. So this is a chronic deficiency. This is, in this case, if you are asking them to go for parenteral injections, so maybe first few shots they will take and then they will lose that. And after that, this deficiency will come back again. So for that reason, if you give oral methicobal thrice daily for 6 weeks, and then after 6 weeks to 3 months, sometimes if the patient is not able to take so many tablets in a day, there are combinations which contain 1500 of methicobal in one tablet. There are combination tablets, which I don't want to mention here, but that also you can try. But also, if you give a pure methicobal, that comes in 500 microgram tablets. So you have to give thrice a day for 6 weeks at least, and then you carry on with twice daily dose for some time, then check and then decide that whether 1 a day or 2 a day will be good enough for your patient. Parental, if you have to go for it and you know that it is a case of perhaps pernicious anemia or Crohn's disease or celiac disease, in that case, that methicobal injection will do. And that there it's a one injection of 500 microgram weekly for 6 weeks, and then you maintain the dose monthly or 3 monthly, depending on the level, and then decide on how long you want to carry on. So that is the problem. So even if it is an IM injection, so but here, in certain part of India or certain, I would say certain part, I would say it depend upon the mentality of the patient. Some patients, they do feel good about injections. This SUI concept is sometimes works very well. So you need to understand the patient psyche as well, number one. Number two, you have to explain to your patients why he or she is a candidate for tablet, not for injection. So dietary improvement along with these drugs, either oral or parenteral, but you also have to advise them to avoid alcohol and avoid concomitant use of antacids. But when you are hitting B12 deficiency, don't forget to check the liver function as well as the folic acid level and treat them concomitantly with B12 deficiency. Now, when we talk about this macrocytic anemia, I told you that this megaloblastic are due to B12 folate, and this non-megaloblastic is myelodysplastic syndrome, liver, thyroid, alcohol, or some drugs that might cause this macrocytic anemia. So all these causes have to be in your mind. Otherwise, if you don't know, you will just focus on one and you will lose the track, or you will lose the patient. This is a much discussed thing when we start talking about anemia. Anyway, we talk about microcytic anemia first. So that's why I started with macrocytic. Now, when we deal with microcytic anemia, the patient said, in many cases, I have seen people are just having iron. Now, my point is that unless you know the cause of low hemoglobin or low iron, and you don't mend that cause, how will you treat the patient as a whole? I mean, the way I explain that if there is a leakage in a pipe and you are trying to fill up the tank with water, then never it will be filled up unless you just seal that leak. So my intention when I see any iron deficiency or microcytic anemia, to where is the leak? So either it could be inadequate intake, it could be impaired absorption, or it could be some loss. So loss in a reproductive age group, very common cause is menorrhagia or a bleeding hemorrhoid, which the patients might not tell you unless you ask them specifically. Hematuria, usually they tell, but if it is microscopic, it's difficult to come up. But menorrhagia is one of the commonest cause. If they are coming to a physician, they might think that menorrhagia is not your domain. So, and particularly female patients with male doctors. So unless you ask specifically, and also male doctors have to ask proactively about this cycle, that how heavy is the cycle, what is the duration of the cycle, to understand, because even after replenishing the loss, you may have to give 5 or 7 days of iron during that menstrual period to keep the level normal. Thalassemia, yes, in our country, not the full-blown, but thalassemia carrier. So they are the candidates who develop low iron. But in this case, unless you do the ferritin level, you will push them with iron, and then you can load their liver with iron and cause some hepatic injury. So please check the ferritin level if you are carrying on with iron in a patient of iron deficiency anemia. Sideroblastic anemia, but sideroblastic may be macrocytic and such like B6 deficiency. Lead poisoning and anemia of chronic disease. Before I go to this anemia of chronic disease, I will tell you a story about lead poisoning. One of my patient is a young male, is 29, has come up with very low hemoglobin, 4 something like that, which and very much symptomatic, had some iron, not responded. Now he required blood transfusion even. And during blood transfusion, we were investigating the cause. Even the hematologists were involved because this young patient, nothing else was there. And suddenly we realized that there is a basophilic stippling in the smear. So then I was asking that man that what you were doing, sir, that you were chewing lead pencil or something, how your blood is containing so much of lead. We did the lead test also. And then sheepishly this man said that he has problem with hair fall. Now it's a kind of androgenic baldness he was developing because of the family problem. I mean, father, grandfather, all of them lost their hair very early, at very early age. So he was taking some Ayurvedic medicine and preparation, which is full of lead. Now that was the cause of that lead poisoning in that guy. So it's an interesting case. So sometimes alternative medicine causes alternative problem. So we have to be careful about it. Now, when we coming to anemia of chronic disease, so we all know that anemia of chronic disease in medical school, we have read it is normocytic, normochromic. But anemia of chronic disease can be hypochromic, microcytic. So that is why it can be both. Now, what are the anemia of chronic disease you think of which can give rise to anemia? So I was talking sometime, you have to think about something now. Anything, Gauri, is coming up?
I'm waiting for some answers, but anemia of chronic disease can be because of, I have an answer here. Rheumatoid arthritis, Dr. Amir says.
Yes.
There could be chronic kidney disease, chronic liver disease, CKD, Dr. Musliha says. So, yeah.
Right. So, yeah, this we will talk about this anemia of chronic disease because it is an interesting topic because we all now deal with the chronic disease. Now, before that, we interpret the microcytic anemia a bit. Now, microcytic anemia, we know that CBC shows low MCV, low MCHC. WBC may be normal or high. It is a we call accused phase reaction. So when you are giving iron, particularly when they are on treatment, they can develop suddenly low high WBC, high platelets. Peripheral smear, yes, microcytic hypochromic platelets usually increase and target cells. You remember round cell with a dot that is absent in iron deficiency anemia but present in thalassemia. And lastly, iron study where you can see that ferritin level and serum iron level are low and elevated TIBC diagnostic of iron deficiency anemia. So keep that picture in mind. So don't think that if the WBC is high, always it is due to infection. If platelet is high, always patient is having some serious hematological disorder. This picture can be a part of iron deficiency anemia or microcytic anemia. And thalassemia, this target cell is pathognomonic, and in iron study, this TIBC, elevated TIBC is pathognomonic of iron deficiency anemia. Now, just by diagnosing iron deficiency anemia, we don't stop there. We just want to see that what is causing that iron deficiency anemia. We can, depending on the provisional diagnosis, because we think that why this patient is developing this. So we can either arrange for stool for FOB, and if the FOB is positive, so nowadays newer tests are there. We can do the colonoscopy or upper GI endoscopy. We can do at least a urine routine to find out if there is microscopic hematuria there. We can arrange an ultrasound abdomen. Measurement of lead tissue is not that we do in everybody, but if there is a strong suspicion, particularly if the blood smear shows ring sideroblast, there you can do. And bone marrow aspiration, but that in that case, it is not your only diagnosis or treatment you will follow. You have to involve the hematologist in that case, if the case is like that. But in the initial, this endoscopy, colonoscopy, particularly in a male or female more than 55-year-old, they have developed sudden anemia, particularly if the weight loss is there, then it is mandatory to do the endoscopies and both the upper and lower one. Even if the FOB you just don't want to do, or if you are not interested, you just get this endoscopy, colonoscopy to make sure you are not missing any GI malignancy, because it is silently that can appear. Even I have seen there is no symptom. Not even weight loss, not even loss of appetite, but they have had some problem in the colon, which is causing this anemia. Cecal cancer, this is another thing. There is a niggly right-sided lower abdominal discomfort and the patient is anemic. And in that case, you might think, oh, it is appendicitis, or it's a worm, or it could be a Crohn's disease, but finally it turns out to be a cecal malignancy. So malignancy is sometimes can come up with this anemia only, so be careful about that. Normocytic anemia. So in this case, it is a heavy slide. So just I am asking you to take 2 minutes break here. And read slowly that anemia with primary bone marrow involvement and anemia secondary to underlying disease. When it is normocytic anemia, so MCV is within the normal range. In that case, we are dealing with this normocytic anemia. Normocytic anemia, where the aplastic anemia, the difference, say myelocystic anemia and aplastic anemia, spleen will help us a lot. If you feel the spleen, somewhere it is big and somewhere it is small, and then you can make out where it is aplastic anemia, myelocystic anemia. Because in bone marrow malignancies, sometimes the cells may be not in the circulation, maybe the bone marrow itself or the spleen itself, then you can get confused. So bone marrow malignancies like leukemia, lymphoma, myeloma, or metastatic tumors. I love this mnemonic republic when I was in medical school. That's how I try to remember that: thyroid, prostate, urinary bladder, lungs, intestine, kidney. So these are the common areas which can give metastasis to bone and can lead to anemia. And granulomatous disease like tuberculosis and sarcoidosis. So these are all causes of anemia with primary bone marrow involvement. But anemia secondary to underlying disease like liver disease, renal disease, endocrine like thyroid, pituitary, adrenal, or chronic inflammation. Here comes the anemia of chronic disease. So again, we will come to that. Before that, we are coming to case 4.
Dr. Audrey, there's a question come up that you mentioned that blood loss and anemia can lead to microcytic anemia. So the doctor wants to know, why not normocytic? Why is it that it is a microcytic anemia when there is blood loss?
Right. So when there is a blood loss, chronic blood loss, I would say just in a day it will develop microcytic anemia. When there is a chronic blood loss, we develop iron deficiency. We are losing lot of iron from the body. So that there the cell size becomes small. That is why it becomes a microcytic. But say we had a huge hemorrhage today and we check the blood tomorrow, it may be normocytic at that time. So it will take a bit of time to become microcytic anemia for blood loss. So acute blood loss is not microcytic. It may be normocytic, even macrocytic if a lot of B12 deficiency and other things are there. But only if it is chronic, it will become microcytic anemia. Is that clear? I hope it is clear now. So it is because of the iron loss, not because of the blood loss. All right. So I'm going to the next case. Case 4, a 50-year-old diabetic patient with easy fatigability, generalized body ache, dizziness, palpitation, inability to concentrate, and low appetite. You understand? Patient with diabetes. So there are some symptoms there. On examination, he is pale. Blood pressure is 100/60, pulse 106, respiratory rate is 22. And blood report shows that hemoglobin is low, 8.4. MCV is 90. So it is normocytic and normochromic. Reticulocyte count is 1, so normal. HbA1c is high here and creatinine is 3.8 milligram per dl. So I forgot to put the unit. So what is going on in this patient? Any thought? Definitely, you have to say something about this patient because this is an interesting case and we just have this kind of patient now and then.
Yeah, so we have an answer. It says this is normocytic normochromic anemia, which is right, due to chronic kidney disease.
Fantastic. So it is a chronic kidney disease, normocytic normochromic anemia, and the patient has uncontrolled diabetes. So this is the whole picture we are getting in this kind of anemia. So yes, you have already said everything, and it is a case of anemia of chronic disease. Now coming to the answer with anemia of chronic disease, chronic renal failure, autoimmune disease like rheumatoid and SLE, infection like tuberculosis or even sarcoidosis, malignancy, this all causes anemia of chronic disease. The doctor who asked me about that blood loss and this thing, say in blood loss, though it is happening chronically, and that causes more iron loss. That is why it is microcytic. But in this anemia, iron loss may or may not happen. That is why it is still normocytic. Interestingly, I have told you renal failure can cause both hypochromic and normochromic anemia, or microcytic or normocytic anemia, because it depends on the other issues associated with renal failure. Renal failure can cause anemia in different ways. So symptom of chronic kidney disease, I know if you come across this patient, definitely you have come across this patient several times. So they have fatigue, they have reduced exercise capacity, they impaired cognition, and as their immunity is low, they tend to get infection now and then. Quality of life is low. The cardiovascular disease develop very soon. New onset of heart failure to severe heart failure can happen to these patients, and it might result in increased cardiovascular mortality. So very often we have come across this cardiorenal failure. So because whether the cardiac problem triggered the renal problem or renal problem triggered the cardiac problem, when the patient come at this last stage, it's difficult to understand. But many a time, because of fluid overload, because of chronic anemia, this patient can develop cardiovascular disease, which might not be the primary one, which may be secondary to the complication of chronic kidney disease. So we are seeing more and more kidney problems. That's why I'm asking you to be more vigilant about this. Now, this erythropoietin stimulating agents in CKD, this is a very hot topic, I would say, because a lot of people in the nephrologists, they are using them. And when we are in a primary setup, we don't know whether we should give them. So if we are not very confident in giving them, at least we need to know what complication they can cause, or how they can be given, or when they can be given, so we can refer them appropriately to the nephrologist. So here, etiology of anemia is one of the main reason of anemia in kidney problem is erythropoietin deficiency. But this iron deficiency, hyperparathyroidism, there's problem in calcium metabolism, which might develop to secondary hyperparathyroidism, and that can lead to anemia. Chronic inflammation, this is in a body, there is a chronic inflammation happens, and B12 and folate deficiency. So all these deficiencies you have to make up and think about whether the patient has got hypocalcemia, hypercalcemia, hypoparathyroidism, hyperparathyroidism accordingly. CRP will guide you if there's any chronic inflammation is going on. And then you have to check the hemoglobin. If the hemoglobin is less than 10, these are the candidates for ESA. Now, interestingly, even if we are giving them ESA, we are not trying to make the hemoglobin 12. We are trying to make them 10 to 11 to avoid certain complications. I mean, even after 11, they can cause hypertension and other comorbidities. So it is better to keep 10 to 11 in that range. And drugs like epoetin alpha, Vipox, or darbepoetin, Crest, these are the drugs we use. So you have to check the dosage if you want to give, and you have to consult with your nephrologist colleague if you want to be a part of that treatment. Route of administration, usually in a community, we prefer subcutaneous, and we have to be careful about this hypertension thing. So in fact, these kidney failure patients, sometimes they are hypertensive, they are on multiple drugs. On top of you are adding one drug which can make people hypertensive. Say there are a lot to just manage. So if you are not really familiar with the drug, it is better not to do that. If you are confident, then only you can do that, but keep a nephrologist involved in that case. So I just put that slide, that adverse effects, because we are not sometimes involved in initiation of the drug or giving the drug, but we are involved in the chronic management. So if the patient is under nephrologist also, if they develop certain complications, they will come to you and will ask that, doctor, what will, this is the problem I am having. Like say, the patient suddenly develop a cough or itching or a rash. They might not think that it is due to this erythropoietin. Now, Itching and rash can happen to chronic renal failure because of hyperuremia, which can deposit it under the skin and cause itching. So how will you know that that is the reason for itching or the drug? Only way you might know that after starting this drug. So you need to know yourself first that this can happen because of this medicine. Pyrexia, if just they have the temperature only after giving the drug, you can simply treat them with paracetamol. Nausea, vomiting usually happens after giving the medicine, so this ondansetron will help. Hypertension, as I have already mentioned, this is a serious consideration to make, and you can adjust the drug if you think that yes, I have to continue with the drug, so maybe we can manipulate with the medication. Cough, itching, rash, headache, arthralgia. So all symptomatic treatment with paracetamol you can do. Definitely kidney patient, you can't give NSAID. Less commons are this, anything can happen with any drug. So these are all these myalgia, stomatitis, these can happen. But at least you need to know that this can happen with the patient with this kind of medication. Case 5, so we are proceeding towards end. Now, a 32-year-old male presents with extreme fatigue and dark-colored urine. He is on treatment for malaria. On examination, he is pale. His hemoglobin is low, 8.4. Blood films shows cystocytes and poikilocytes. WBC is normal, platelet is normal. Bilirubin is showing slightly high bilirubin with more unconjugated bilirubin. Haptoglobin is low, LDH is high, reticulocyte is 3.8. What is going on? Any answer? I think a lot of people are taking interest in it, so I'm also interested. Yeah, some answer has come.
Hemolytic anemia is the answer.
Yeah, it is hemolytic anemia. So what is the cause of hemolytic anemia in this patient? He is on treatment for malaria, I have said. So is there anything in the treatment that might cause it? So more answers are there, Gauri. Can you read out?
Dr. Amir is saying it's anti-malarial, but I think you're specifically asking for the drug, right?
Yeah, is it possible?
Condition.
Yeah.
We have an answer. Quinines could be a possible causes. What is the answer?
Anything else is coming up? Yeah, I did mention that which stage of malaria treatment the patient is. This is if you come across this patient, actually, I don't know whether you know about this G6PD deficiency. If a patient, there are two types of malaria. We know there is a vivax malaria and falciparum malaria. Falciparum malaria, one of quinine you give, and vivax you have given chloroquine, the patient relaxed again. So what to do? You have to take a preventive course. So when you take a preventive course, we usually give a drug called primaquine for 2 weeks. Now, if you don't check the patient G6PD and give primaquine, this can happen. So when you are encountering a patient of vivax malaria and you have initiated them on chloroquine, at the same time, you send the blood for G6PD so that when the patient finishes off with this chloroquine regime and you think about giving primaquine, your result of G6PD is with you. If there is no deficiency, go ahead, give primaquine. If there is deficiency, please don't give, because you will come up with this patient. It happens. So yes, when we do a standard test, so all the things were there, this particularly reticulocyte count, and this haptoglobin, lactate dehydrogenase, these are important here, and indirect bilirubin is raised. But reticulocyte is one thing which is clinching. So features, you know that low hemoglobin, there may be pancytopenia, all the counts may be low. MCV is depending on the cause, it may be high or low, unconjugated bilirubinemia, reduced haptoglobin, increased LDH. And why I put it on red, that one thing, if you forget everything, then you should remember. But there is a immune hemolytic anemia cases sometimes rarely we encounter. There we have to do Coombs test, but it is a very special test. Here the hematologists usually do it. And splenomegaly sometimes help us, because in the splenomegaly, this is the site for destruction of the blood cells. So in that case, the platelet count will also low. In the cases of splenomegaly, you might see a feature of hemolytic anemia. Some answer is waiting, Gauri, there. I think, if question, I don't know.
None at the moment, Audrey.
Hemolytic anemia. So interestingly, it could be extravascular, intravascular, intermedullary, but in our country, the important bit, we need to know this G6PD deficiency. COVID-19, we are seeing cases with intravascular hemolysis, ABO and incompatible transfusion, definitely, we all know that that can happen, and thrombotic thrombocytopenic purpura. So if you see that the platelet count is very low also, then also think about this, and there you have to go for specific test. Pernicious anemia, that's not that common. Thalassemia, yes, that can happen, but it's any early age. So if you are dealing with adult patients, you won't see. But there is a condition called thalassemic intermediates, where the hemoglobin count is something like 7, 8, but they survive. They sometimes have huge spleen, and splenectomy sometimes helps for their survival. So these are the cases. And where the splenomegaly is the cause for anemia, particularly this hemolytic anemia, there the treatment of choice is splenectomy, but we have to give the immunization for this before splenectomy with the encapsulated organism, viruses or germs, so that they don't develop very fulminant infection just after splenectomy. So that is very important. Drugs to discontinue in suspicion. So definitely if I put a list of drugs, you won't remember. So I have just mentioned a couple of things. So why it is important to ask about drug allergies. So these are the few drugs which we use very commonly: penicillin and cephalosporins, rivafloxacin, nitrofurantoin, NSAID. So say we are not that used to using dapsone or methyl dopa, so or even quinine, quinidine, but these are particularly nitrofurantoin. All the urinary infection patients nowadays are on nitrofurantoin, even they are self-medicating. NSAID, yes, we give. Levofloxacin also they are using randomly. So these are the drugs which can cause hemolytic anemia. So you need to ask the patient. G6PD drugs, as you have seen, but yes, primaquine is the main drug. Chloroquine also sometimes cause, but primaquine is the main culprit. That is why we don't check G6PD before chloroquine, giving chloroquine, but definitely before giving primaquine, we check. But the sulfur drugs, again, we know that nowadays we rarely use sulfur drugs. Nitrofurantoin in both the cases, G6PD, but fortunately we are not seeing that many of cases of hemolytic anemia in a case of nitrofurantoin. But when we were doing the teaching stations before, we always see that when we talk about or discuss about something, later on this case come the next week or next month. So maybe we are not vigilant about it, but this can happen. So be careful about using these drugs. So thank you very much for this. I know this is a difficult session. So to keep your concentration right throughout the session, it's not easy, but I try to make as interesting as possible. If you have a feedback, please let me know that how you want to have it. So, so that we can make it more interesting. Thank you.
Thank you, Dr. Audrey. I think it was a fantastic session to understand the different ways in which a simple hemogram that we see so common, I think, and these days we have patients who do their bloods and come to us with the reports, having diagnosed themselves or possibly thought of it themselves. So it's important that we see our reports from that perspective. And this was, I think, very great. I have a few comments on the chat saying thank you, and it was very helpful. If there are any questions, please feel free to ask here. I see that a couple of you are raising your hands. If you're raising, just click on the Q&A section. And you could just type out your question if we can take it in the next minute or two. Else, you can always email us at hello@medibuddy.in and we'll get your questions answered for sure. So if there are any questions, please let us know. We'll wait out for another minute. Doc, I don't see any questions coming in, but I think it was quite an interesting session for me. There's a question here coming which says gastritis due to iron supplements, how to treat it?
Right. So interestingly, that as you said, that when any gastritis happens, we give PPIs. But if the iron supplement is causing gastritis, if you are giving PPIs, it won't help with the iron supplementation. So first thing you have to think about change of formulation. One formula, say fumarate is giving, gluconate might not. Second is change of the timing of the medicine. So if you are giving in the morning, say after breakfast, say give it after lunch and see whether that happens. If that is also not helpful, you can give PPI in the morning and give iron in the evening, rather than giving both at the same time. But itself, the iron deficiency can give that post-cricoid wave and all these things and cause gastritis. So ask the patient be on regular diet, the diet rich in iron, and change the formula. Try to avoid the PPI if possible, give liquid antacids instead, but also keep a gap between the two and see whether that helps or not.
Thank you, Dr. Adrisha, for taking up the question. I don't see any other question coming in. So thank you so much, Dr. Adrisha. It has been a fantastic session today. Thank you all participants for actively getting involved in the session, and have a good evening here ahead. And do catch our sessions on our YouTube channel and also on our monthly CME sessions. I'll be letting all of you know the next session. Thank you. Good day.